Hello, this is Dr. Maite Sandrin from Diabetes and Endocrinology, here to give you a talk regarding diabetes education and exercise called Lifestyle Interventions in Diabetes Management. I've taken the information from the Journal of Clinical Endocrinology and Metabolism, JCEM, from Supplement 2 from April 2025. Here it is. The information that I've provided is taken from 2 articles published in that supplement. So let's get started. Lifestyle interventions for diabetes management, starting with diabetes education. Diabetes education, which we provide, improves hemoglobin A1C. One of the main studies discussed in the journal, the Diabetes Education Program study, the hemoglobin A1C reduced by an average of 0.93% after 3 months and remains statistically significant at 12 months follow-up. In our program, I know that based on surveys that we can reduce the A1C between 0.5 to 2 percentage points after the program. Diabetes education reduces emergency room visits, it reduces hospitalizations, and reduces costs. The cost determined after taking into account the cost of the education itself, of course, cost savings per patient estimated between $500 and $800 per year per patient in the diabetes education program study. And more extensive education programs offered in other countries, covered in other countries, have shown a much greater reduction in cost per year, up to over $2,000 when transferred to our money, including 2.5-hour sessions over a 6-week period, as offered in some programs in England. Diabetes education is received by less than 7% of people on private insurance in their first year of diagnosis. And that's really when the most impact is with the first year of diagnosis. And in a survey, less than half reported ever taking any diabetes class. And I'm not surprised by that, because I see a lot of patients that come to me that they claim they've never had any education. Or maybe if they did, they just barely remember it, which is, I think it's an ongoing process. And after initial education, insurance usually does cover yearly continuing education. Every insurance is different, but I know that at least 2 sessions per year for our one-on-one visits or our class is usually provided by Medicare, for example. Diabetes education obstacles other than insurance coverage include accessibility. People are busy during the day, but we don't just have classes, we also have one-on-one visits. Hopefully in the future we'll have more opportunities for education, formal education with video visits. We'll see, but I think that would be very important, because education, just learning about your disease process and what the general advice is at the time, learning in a classroom setting is important. You hear about the questions others have that may apply to the patient that's in the classroom. So there are many different options that I think should be considered in the future, but right now what we offer is the class and one-on-one visits. In diabetes education, patients learn about the complications of diabetes, different treatment options, side effects of medications, managing glucose fluctuations, how to avoid hypoglycemias, different diets to help the diabetes, adjusting insulin, and importance of exercise, which is a lead-in to my next topic here, exercise for diabetics. There are multiple types of exercise to improve glycemic regulation, by improving insulin sensitivity, improving blood flow, and it can last up to 48 to 72 hours after doing the exercise in both type 1 and type 2 diabetes, and there is significant reduction in hemoglobin A1C. The benefits of exercise, it's most effective in early disease, of course, in patients that are not on insulin and have less complications. So, we should recommend exercise for everyone, but it's best to start talking about that early on and not have any preconceived notions about what the patient may think or what the patient's able to do, because any type of exercise is good. But it's best to start early to build the habit and improve insulin sensitivity from the start and improve pancreatic function. The types of exercise we're talking about for aerobic, it could be walking, cycling, swimming, in low intensity or high intensity, depending on the patient's ability. Also important to do resistance exercise to help to build strength and reduce the risk of falls. You can do it accumulated several times a day or in large chunks of time. The aerobic exercise recommendation minimum is 150 minutes per week, and that first came from the diabetes prevention program many years ago, but more recent studies show that an ideal average is more like 240 minutes per week. And you should aim for a target of 150 to 300 minutes per week, spread out over 3 days per week or more, no more than 2 consecutive days without activity, because you really want to build a habit. My advice is to plan to spread it out over 7 days, meaning every day you do exercise, and you start small with at least 10 minutes per day, but the goal is to achieve to 30 to 40 minutes per day. Or more if possible. And as life happens, you will get your days, your break days. You have a meeting, you have an event, you're feeling sick or whatever, life is gonna give you the break days. So it's better to just plan for doing exercise every day, and you can alternate the types of exercise to avoid muscle fatigue, but it's best to just keep it going every day, and eventually you'll hit a pause day that you don't exercise for whatever reason, but you want to build the habit. I tell my patients that exercise is like a medication, and when you see all the benefits of exercise, it is certainly better than any medication. Aerobic exercise improves insulin sensitivity before it improves weight loss, before showing any signs of weight loss. It promotes peripheral insulin action more than hepatic insulin sensitivity, although it does do both. It's just more peripheral insulin action, as it's kind of obvious because of the movement of the muscle. It reduces hemoglobin A1C anywhere between 0.5 to 0.7% on average in type 2 patients. 70% of patients see very quick reduction in the A1C, but 30% of patients it takes longer, and it appears that this is more likely due to patients who have had diabetes for a longer period of time, probably take insulin or sulfonylureas, and they need to reduce medication, stop medication, and in that interim, it's more difficult to see an A1C reduction. The resistance exercises are engaging muscles to overcome resistance or force to increase strength. Type 2 diabetes is an independent risk factor for low muscular strength and accelerates the decline in muscle mass. Thus, resistance exercises combat the increased risk of falls from sarcopenia and augments insulin sensitivity by 48% in one of the studies quoted in the review that I read. Skeletal muscle is responsible for 80% of insulin-mediated glucose uptake, thus increasing the muscle mass and quality is expected to benefit glucose control and pancreatic function. To me, it seems kind of obvious. The best type of exercise, all of the above, concurrent, or doing both resistance and aerobic. Recommend alternating days between aerobic and resistance exercise, or spend some time doing resistance exercise first, followed by the aerobic exercise. Sometimes resistance exercise, because of the increase in the stress and effort, can cause a little bit of hyperglycemia. So you have a cool down period after that, and then do the aerobic exercise. That's more likely to cause lower blood sugars post-exercise, but doing the resistance exercise first can help balance that out better. So also in patients that are able to do it, vigorous intensity exercise could be done, and it can require less time. Instead of doing 150 to 300 minutes a week, you can do 75 to 150 minutes a week if you always do vigorous intensity exercise. For the majority of my patients that I see on referral, most of them are not able to do that. But you can try to, if a patient has low complications and they don't have severe osteoarthritis or knee problems or heart problems, then you can promote them doing this at least one time per week. From my experience, just getting them to exercise at all is a big win for me. So I haven't been really promoting vigorous intensity exercise. I am so glad when it does happen, and that's usually the patients independently decide that. Very few of them, unfortunately, but I'm just happy just to get them moving. Because most of them, like many Americans, have a very sedentary life. So dealing with a sedentary life is a problem, but there are solutions. Sitting or lying down while awake increases the risk of type 2 diabetes across all ethnicities. An extra hour of sedentary time over an 8-day period is associated with a 22% increase in the odds of developing type 2 diabetes. In type 1 diabetes, sitting without interruption for more than 2 hours at a time or across the day raises the risk of obesity and worsening diabetes management, and also promotes nocturnal hyperglycemia. In the United States, adults spend an average of 8 hours per day being sedentary. So the solution, break it up. Break up this average with exercise interruptions. 3 minutes every 30 minutes. This has been research proven to be beneficial for glycemic control, or 5 minutes every hour, or replace the sitting with standing, or exercise breaks or interruptions like walking, simple resistance activities like half squats, calf raises, knee raises, gluteal contractions, what they call exercise snacks, like isolated bouts of vigorous exercise for less than 1 minute, like climbing up and down the stairs. I don't want anybody to get injured. And that has a lot of cardiovascular, cardiorespiratory benefits. The exercise timing, when to do it. People with type 2 diabetes have disrupted circadian rhythm. They have insulin sensitivity that's better in the evening, and worse throughout sleep and early morning. So physical activity or exercise in the afternoon or evening has been found to be more beneficial for type 2 diabetics. And it's beneficial for circulating glucose and insulin sensitivity compared to equivalent activities performed in the mornings. But morning exercise is better for weight management and activity adherence. Postprandial exercise provides better glucose control by attenuating acute glycemic spikes regardless of exercise intensity or type. And it also reduces acute elevations in serum triglyceride levels after high-fat meals. So exercising best in the afternoons or evenings for most type 2 diabetics. For people trying to lose weight, is better to exercise in the morning, and preventing spikes post-meal, and even improving triglycerides, a little bit of exercise, a little bit of activity after the meals. I recommend for my patients to try to wake up earlier and always exercise first thing in the morning, because that causes them to develop a healthy habit of daily exercise. Of course, because of the research, I've started recommending also exercising in the evening. But I feel like if you tell them to just wake up early and just get it out of the way first thing in the morning at the bedside, doing the simple exercises, simple resistance activities, and some simple aerobic activities that they can do, that they can tolerate, get it out of the way, and then when they come home from work, find another few minutes to do it. That way, they can do the accumulated version instead of a big chunk of time. And I think that's better for endurance, for dealing with muscle fatigue. They can do 15 to 20 minutes in the morning and 15 to 20 minutes in the afternoon. Plus, after they eat lunch and after they eat dinner, I know after eating breakfast that it's going to be complicated because I have to rush to work, but after eating lunch at work, take a little bit of walk, have a smaller lunch, do a little bit of walk around the office, go up and down the steps. Do need an elbow if you're too busy to do anything else. Do need an elbow in the office or punch the air for a few minutes. And then after dinner, instead of just sitting down, wash the dishes, clean up, do something active after dinner. Don't just leave the dishes there and do it later. Just immediately after dinner, do something. Then I think you accumulate the amount of time of exercise or activity that would be ideal. In type 1 diabetes, exercise improves cardiovascular fitness, improves body composition, increases muscle strength, improves lipid profile, improves insulin sensitivity, increases life expectancy. And in type 1 diabetics, they do better with the morning fasting exercises rather than with the evening, because when they do exercise in the evening, they have a greater risk of having hypoglycemia overnight. So for them, the research shows it's better for them to just do exercise earlier in the day. Okay, so bottom line, educate the patients about diabetes. It's very hard to do that in the office setting. You can always educate in small chunks whenever you see the patient, of course, but having a formal diabetes education is very important because it has shown reduction in A1C and improvement in all risks. And improvement and reduction in hospitalizations and ER visits. They learn a lot, at least in our program. They also learn about hypoglycemias and about nutrition. And it's very important to encourage patients to exercise on a regular basis. It's like a medication. And I don't have time to go into an exercise lecture that I used to give years ago, but it's amazing what exercise can do. Yes, nutrition is the most important thing. But without exercise, you're missing a big part of health. So please always promote exercise in patients and just keep it simple. They don't need to own equipment. They don't need to go to the gym. They can do it at the bedside. They can do it at home. All they need is gravity and movement, okay? Thank you so much for your attention. If you have any questions, please email me or call me. Call the operator if you don't have my number. I'll happily give you my number so you can keep it in your contacts. Okay, thank you so much.